Good morning, everyone. Thanks for joining us on a Wednesday morning to this BHRS webinar on heart failure and CRT and how we're managing this as we move forward in the post-pandemic, optimistically, he says, phase of medical practice. We've been forced to change a number of aspects of our practice, and I think the talks this morning will reflect on how well we've managed to adapt and what changes that have taken place should stay, and whether some aspects of our care should revert to how we practiced pre-COVID. I'd like to thank the teams from Oxford and Manchester, and in particular Anna and Cristiana, for putting together this excellent programme with physiologists and physicians contributing to the morning's education. Without further ado, I'd like to introduce the first talk. Dr. Fozia Ahmed, heart failure consultant in Manchester, is going to talk to us about heart failure management in the post-COVID era. Thanks, Fozia.
Thanks, Alistair. So hopefully you can see my screen now and hear me okay. So I'm going to be talking to you about heart failure management post-COVID. Specifically, I'll be talking to you about how heart failure care for patients with devices has changed over the last 24 months. With a renewed emphasis on how we can digitalize aspects of heart failure care, learning from how device teams and device clinics do things differently. And I'll be looking at how we can potentially make some of these digital changes stick post-pandemic. So COVID has been a huge catalyst for digital transformation, both in device space and also in the heart failure space. And many of us over the last 12, 24 months have sought to try and digitalize aspects of our heart failure care pathway in the same way that device clinics and device services have been digitalizing their care pathways over the last decade or so. Because for the first time, we're realizing the utility of how we can use device-based diagnostics and technology to not only potentially predict, but also possibly prevent some of those heart failure hospitalizations. To understand why it's important to digitalize and transform in this space, we need to consider the impact and burden of heart failure on our day-to-day practice. From a heart failure perspective, we're looking at over 1 million, or close to 1 million patients living with heart failure in the UK. And today it is one of the few cardiovascular conditions whose prevalence continues to rise, often at considerable cost as well. We're looking at, on average, 90,000 heart failure admissions each year in the UK, so we're approaching 100,000 admissions each year. And today, heart failure is the leading cause of cardiovascular bed occupancy in our hospitals. And things are only ever expected to get worse. We're anticipated to see a projected rise in UK heart failure admissions by at least 50% over the next 15 years. But why, despite significant advances and investment in drugs and therapeutic devices used to treat heart failure, is this the case? Well, one of the problems is that our approach to the management of the decompensating patient remains very much low-tech, not very digital, paper-based, and very manual process. And we miss opportunities to identify decompensating patients at an earlier time point. So we often intervene too late in the day to make a difference to these patients and avert heart failure hospitalization. But what we learned from devices is that devices perhaps give us a window of opportunity in which to detect physiological changes at an earlier time point to try and identify these patients to heart failure teams so that we can potentially introduce more simpler, straightforward changes with oral medications that could transform a heart failure exacerbation and prevent it from translating into a hospitalization. So this concept of early detection, creating a window of opportunity in which to perform simple, possibly even remote interventions to change the clinical course and clinical trajectory for those patients. The other thing that we need to bear in mind is that since COVID, many of us have reset and restructured the way that we deliver heart failure services as well as device services. And for many heart failure services, there's been a hybrid clinic model approach in that now a significant proportion of our in-person assessments have been replaced with telephone or video consultations. In Manchester, we don't really have video consultations available to us. So for the most part, a lot of those telephone consultations have been lone phone call based consultations in the absence of any available diagnostic data being made available to the heart failure nurses. And this highlights the fact that we need to not only just take on what appears fashionable and what's on trend at the moment, but we need to acknowledge the limitations and the negative aspects of performing lone phone call based consultations in the absence of any diagnostics, because there is a degree of imprecision with them, but also they lack a lot of the clinical data that we've come to take for granted when we see patients face to face, even if just for a few minutes. This is data from the US, but it is a reminder of the potential negative consequences of adopting new things too quickly without looking at the data and using data as an asset by which to guide the way that we deliver care. What it showed was that remote visits for heart failure care were associated with reduced diagnostic testing, decreased prescription of guideline-directed medical therapies, which we know improve outcomes for patients, and that telephone consultations, but not necessarily video visits, were associated with increased 90-day mortalities. So it's important that we just be mindful of new things when they're introduced. Heart failure teams across the country are now starting to develop a growing list of problems that they're wanting to tackle. And some of these problems are outlined here. So we have rising problems with numbers of admissions. We have a problem with remote phone call consultations undertaken by many services in the absence of any available diagnostic data. And we need to rapidly triage the hundreds of patients who are on our waiting list awaiting a face-to-face appointment. And God forbid, should COVID worsen, we need to also think about or have one eye on how we would manage delivering specialist care in a home environment, should things worsen. With that in mind, many people and many services are looking at new approaches for how we can embed remote management of heart failure into aspects of our service, with a view to seeing whether this can help us improve care, reduce unplanned admissions, and reduce costs. So one potential solution to addressing some of those unmet care needs is to use device-based technologies to digitalize aspects of our heart failure care pathways, but also digitalize de novo in other areas. Looking at this from a heart failure perspective, up to a third of heart failure patients have an indication for an implanted device, but historically, heart failure and device teams have managed patients as independent teams, and even our educational opportunities are often split. We have conferences for heart failure specialists, we have conferences for device specialists, and never the two shall meet has been the historical kind of status quo or rhetoric. But one of the things that we've learned from devices is that by making things more digital and by looking at specific aspects of remote monitoring, it's possible to do things differently and to optimize and align patient care pathways so that the device is the thing that joins up the heart failure and device care pathways to the benefit of the whole patient. If we look at things from a slightly different lens, if we think about our ICD and CRT clinics now, we're looking at around about 80% of patients having a history of symptomatic heart failure in those populations. So actually, depending on which angle you're looking at it, viewing it from a heart failure perspective or viewing it from a device-based perspective, the size of the prize changes and varies, but definitely for cardiac device clinics, aligning heart failure care could only be a benefit. Many of you are familiar with using remote monitoring tools for the management of patients with heart failure. Medtronic have Triage HF and Boston Scientific have HeartLogic. They're the two most commonly used device-based diagnostics when it comes to heart failure management. Abbott have CardioMEMS, but that is for the most part limited to a smaller number of sensors and doesn't use a cardiac device per se. Just a quick reminder, but I guess in terms of the audience, being that you're all going to be from the device services, you probably don't need this introduction. Boston Scientific have HeartLogic and the HeartLogic Index and alerts, and that uses data from up to 5 different monitored clinical parameters. And this data is being continuously monitored. Whenever the change in sensor data is represented in the HeartLogic Index, and whenever a significant shift occurs, we see that value goes up in association with worsening heart failure. And whenever the threshold is crossed, an alert is sent to the clinical teams to notify them of a significant shift in health-related data. Along similar lines, Medtronic have Triage HF. This uses data from up to 9 different monitored clinical parameters to calculate the individual patient's risk of heart failure hospitalization in the next 30 days. The more abnormal the physiological parameters, the higher the risk status. And whenever a high risk status is generated, then an alert is sent to the clinical teams to notify them that there's been a significant shift in this patient's health-related parameters. So for heart failure nurses, where their services are using or embedding remote monitoring technologies a lot more, we're seeing them be able to better understand what's driving those decompensations in patients. So an alert comes through And accompanying the alert, there is a heart failure management report, whether that's HeartLogic or whether that's Triage HF that you're looking at. And it helps us to better understand what's driving that decompensation. So for example, when you speak to a patient over the phone, they may be experiencing breathlessness and swollen legs, but you don't know what's necessarily driving or the mechanism and etiology of that decompensation. But now device-based data can give you insight into the underlying reasons. So in the panel on the left, we see that this patient, and this is a patient just before COVID, so it was January 2020, the patient had transitioned from paroxysmal through to persistent atrial arrhythmia. We see that this is associated with an elevation in day and nighttime heart rates, persistently elevated heart rates, and that there's an associated increase in congestion. And this is associated with the high heart failure risk status. So in this instance, this might not necessarily be a case of optimizing guideline-directed therapies, but rather engaging with EP and device services to arrange a cardioversion or to discuss ablation. By contrast, the patient on the right-hand panel, this is now a picture of predominantly congestion. So actually there's no arrhythmias going on. What we do see is that this is a case of increasing oxyvol index associated with a sudden decrease in activity levels from 2 to 3 hours down to extremely low levels. And there's an associated elevation in heart rate that we see as well. So this would be a case of optimizing the diuretics, optimizing guideline-directed therapies. And in this instance, this was a patient who had been discharged from the heart failure service many years previous, had been well and stable in the community, but he was on relatively old medications, so ACE inhibitors, beta blockers, and an MRA. Whilst being able to identify this patient through device-based monitoring, we're able to update his medication, optimize his diuretic regime, switch to Entresto, and seek to optimize therapy. So it gives us unique opportunities to be able to treat patients differently and treat patients better using additional data. So we're starting to see data as a strategic asset by which we can help manage our populations. And what risk-based monitoring does for services that have been heart failure services that have embraced digital technology or device-based technologies, it allows us to identify those individuals who are sat there in the community whose health-related data is the most abnormal and identify them to specialist teams or heart failure teams for review. But perhaps more importantly, as we emerge from COVID, one of the things that it does is it allows us to stratify our population and to reapportion and redistribute resources on the basis of clinical need. It provides us with a way to monitor patients in between their routine scheduled appointments, so that in between those 12-month appointments, there's some continuous monitoring and a way for us to bring that patient back to our attention should the need arise. Beyond that, what we're also doing is using it to identify patients whose, we mentioned earlier, whose medication regimes need updating. So identifying unstable, decompensating or suboptimally managed patients to ensure that they're on contemporary guideline-directed medical therapies, which include ARNIs and which include SGLT2 inhibitors as well. So there are some key differences in device and heart failure services, but this represents some new opportunities for us to align our services better. Thinking about device services, for over a decade, these have been high-tech, digital, paperless for the most part, with a focus on remote monitoring. By comparison, patients with heart failure and a cardiac device, for their heart failure care, their care is very much paper-based, not very digital, a lot of manual labor, and no real focus on tech or remote monitoring. And so when a patient has a cardiac device, it can help us bridge that digital divide and augment the heart failure care. In Manchester, one way that we've been able to align our heart failure device services better over the last few years is through using remote management heart failure care pathways as part of one small element of our practice. So this is Triage HF Plus. The heart failure nurses have access to CareLink, and whenever a high heart failure risk status is identified, they're able to undertake a short phone call based assessment with the patient to screen them for indicators of worsening heart failure. New and acute issues are identified and actioned, but we also use that opportunity to optimize guideline-directed therapies. Established in 2016, the service is nurse-led, patient-centric, and it's transformed the way that we deliver care for patients in our area who've got a compatible device and heart failure. And I'm sure Anna will talk to you a little bit about the physiologist-led service that's also running. And the process isn't labour intensive. The whole process from phone up to phone down on average takes 10 minutes. So how do we make digital stick post-pandemic? I'm going to run through this slide in the interest of time, but device-based technologies allow us to bridge the digital divide and bring heart failure care up to date with contemporary practices and contemporary medicine. So I guess to summarize, it's impossible to do a talk during COVID without referencing the impact that it's had on healthcare. It's been responsible for the exponential growth and been a catalyst for digital transformation across healthcare. And with that, it's brought new opportunities for us to digitalize in this space. And by digitalizing healthcare, we're able to, for the first time, start to expand precision medicine programs or start to even think about them. We're able to transform the way that we care for patients and hopefully improve patient experience. And in doing so, try and achieve better outcomes at lower cost. But in order to achieve these metrics or achieve those outcomes, we need to adopt that concept of zero-based thinking. That is, that if you were to ask to design your service tomorrow, in the light of how we live post-pandemic, what would you do? And I think many of us would want to try and digitalize patient pathways. We'd want to transition from paper-based to paperless and start to use data or patient data, health data, device data as a strategic asset by which we can better manage our services and individual patients alike. But to do this, we need to simplify our clinical workflows. It's crazy that within the same hospital, we manage our patients differently across different sites, and then nationally, we all have very different ways of doing things. And that variation can sometimes be good, in which case we should all be doing that, but variation can also be bad and introduce problems. And we need to simplify workflows to empower data-driven decisions and standardized care. When we digitalize healthcare, suddenly we find that care teams are better connected and patients benefit. So COVID has radically changed device care. We've seen accelerated adoption of remote-only follow-up and alert-based monitoring across all device types, not just high-power devices. But by comparison, the digital transformation of heart failure care has very much lagged behind. But devices present a new opportunity for us to take a different approach and align device and heart failure care. And that gives us the opportunity to better manage and monitor our populations, especially populations who decompensate frequently in the outpatient setting. And going digital makes this kind of impossible task a bit more possible. So the concept of close monitoring, frequent management becomes a lot easier to do when we embrace digital technology. And I hope that I've kind of set the scene for some of the talks that will follow in the next few minutes. Thank you.
Thanks very much, Fozia. Fascinating talk. I think in the interest of time, we're going to have to move on. I haven't seen any questions in the chat. So without further ado, I'd like to welcome Cristiana Monteiro, lead cardiac physiologist from Oxford, who's going to talk to us about the evidence behind CRT optimization. Looking forward to this.
Hello, good morning. Can everyone see my slides? Yeah, good. Most often asked question of 2020, 2021. Anyway, so my name's Cristiana, and as Alistair said, I'm the lead physiologist at the Radcliffe Department of Medicine for Oxford University, and I'm going to talk to you about something a bit less COVID related, but the basis of why we're here, so the evidence behind CRT optimization. So I have no conflicts of interest to disclose. So when you put in a CRT, and we do this in very routine practice nowadays, we have a set of expectations, and this is normally our expectation. You do an implant and you have a happy patient. Now, expectation versus reality can be quite different. 70% of our patients are quite happy, they're responders. So they do well, they have an improvement after CRT therapy or with CRT therapy. 5% are super happy, they're super responders, and their cardiac function, their ejection fraction normalizes. They go back to having a normal heart with CRT therapy. However, we have 10% of non-progressors, so patients whose condition doesn't really change regardless of CRT. They don't significantly improve or worsen. We have 10% of non-responders, so patients who don't respond to CRT, so they will worsen over time. And then we also have 5% of negative responders, so patients who do worse after they've had CRT. And really, the people we want to address with this session is this group, the non-progressors, the non-responders, and the negative responders. So 25% of all our CRT patients. So the main thing we focus on nowadays is patient selection, and I think we can all agree we're already doing that quite well. We know which patients to select, which ones will do better post-CRT, left bundle branch blocks, wide QRSs, low ejection fractions, and so on. So we do that quite well. We're doing quite well with the implant as well. We know which veins to target, posterolateral, lateral veins, where most of us are using quad leads in routine practice. So we have lots of vectors to choose from. So the procedure itself and the patient selection were already quite good at that level. But what do we do next? In terms of lead position, so during implant, we're using QLV, or I'm hoping most of us are using QLV. And basically what I'm going to do throughout the talk is just mention a couple of papers for the different measurements were advised to take during practice and that some centers already follow. A study by Khan et al. Showed evidence of using QLV, so lead position guided by physiological parameters rather than anatomic location, so just focusing on the postlateral and lateral veins, base versus apex, has shown a better predictive value for reverse modeling, remodeling, quality of life, and clinical events. And with QLV, what we're doing is targeting areas of late electrical activation. The later the electrical activation, the more you have to pre-excite, basically. And this is associated with better response. Now, you can do this during implant, but not during follow-up. So there is a different measurement, the RV to LV activation time, which acts as a surrogate of the QLV. So it measures the electrical resynchronization that we hope to achieve in the future. And it's basically, again, a delay measurement of how long your electrical stimuli take to get to the LV. And it's also a strong independent predictor of reverse remodeling and quality of life. And this was noted on a multi-center trial by Gold et al. You might ask, we've chosen a vector, why retest them after implant? There's a number of reasons. Obviously, we have acute lead displacement and we have threshold rises post-implant. The other thing we also need to consider is reverse remodeling. If everything goes to plan, there will be a level of remodeling and your vector that you chose initially might not be the best anymore. And another small study, which enrolled 22 patients, a single center study by Lund Anderson et al., showed that in 18% of those patients, testing and reprogramming of all vectors resulted in significant reduction of the paced QRS duration compared to standard programming. Now, there might be a caveat here. This standard programming was at physician and physiologist discretion, so we don't really know what we're comparing with, but this is some of the data we have. Now, you've tested the vectors, you've chosen the vector, and then you have the rest of the optimization process. What a lot of centers do, and it might be due to time constraints, staffing constraints, is just leave patients with out-of-the-box settings, so nominal settings. What these three studies showed is that this might not be the best option. So Varma et al. Run a study, single center, 75 patients, which show that out-of-the-box settings do not account, as we know, logically for PR intervals, which vary widely among everyone, among the general population, but most in CRT candidates who will be normally an older generation who already have a degree of conduction disease. Another study, single center, over 1,000 patients, I'm not going to try and pronounce that name, showed that left ventricular mechanical dispersion reflects heterogeneous mechanical activation of the left ventricle. And Fung et al. Show that LV endocardial activation sequences in patients with chronic heart failure in left bundle branch block are variable. So not only we have variable PR intervals reflecting conduction disease, but due to the systolic LV failure of these patients, we also have varied delays in the way the left ventricle is activated. So out-of-the-box settings are not going to work for all of these patients. They might work for some, but we need to make adjustments according to patient. Every patient's unique, and therefore device programming needs to be personalized, and algorithms can only do so much. They definitely help, but again, they're algorithms. They come with out-of-the-box settings, nominal settings, so there will be a bit of tweaking that is required. In terms of VV and AV optimization, we obviously optimize them separately, but there is a bit of give and take. In terms of the VV interval, if your VV is too short, you're not going to have enough time to pre-excite the lateral wall, and you need time to depolarize the left ventricle before you try and activate the right ventricle. And if your VV interval, your VV delay is too long, you might get too much left ventricle. So you might potentially be making things worse by broadening the QRS even more. And this shows us it's time to focus less on the positive V1 and more on a 12-lead ECG pattern. What we should really be aiming for is ECG normalization. A positive V1 is a helpful, quick measure to see whether we are getting LV activation, whether we're getting LV pre-excitation, but ideally a 12-lead would show more reproducible results. And again, Varma et al. Demonstrated this. Ideally, we'd have biventricular mapping and hemodynamic studies to show that CRT is working, and specific CRT settings are working for different patients. However, this is obviously not achievable, not for our sake or the patient's sake. So a surface ECG, which is widely available and reproducible, is a very good substitute. A QRS narrowing is an intuitive surrogate of biventricular mapping and hemodynamic studies in order to show a degree of resynchronization. And moving on to AV optimization. Again, there's a bit of give and take. If you have an AV delay that's too short, yes, you will be ensuring there is biventricular pacing. You're not allowing intrinsic conduction to come through, but you're going to have poor left ventricular filling, so low diastolic volumes, which will then produce reduced outputs. So you're optimizing systolic function, but you could be doing better. And if you have AV delays that are too long, you will, of course, run the risk of having loss of biventricular pacing, but you might also have diastolic MR, and therefore that backwards leak will then give you a reduced output again. So same effect, you might be improving the systolic function, but what you're doing is worsening the diastolic function. And cardiac output needs both. And the other thing we also need to consider is the effects of heart rate and remodeling. We want these patients to become more active and live a life that's as normal as possible. And we know that physiologically, the AV delays and also the VV conduction change with heart rate, with increasing heart rates, and with remodeling. Hopefully, both intervals will get shorter with these two events. And for this reason, fusion algorithms like adaptive CRT or sync AV have come into play. Again, Varma et al. On this study, they've tested different settings, and what they've shown was that nominal static settings, so out of the box fixed AV delays and VV delays, have little effect and may sometimes even be detrimental in comparison to these patients baseline QRS, you might actually be broadening the QRS by turning on one of these fusion algorithms, in this case, SYNC-AV. These patients performed better, and there was a further improvement by tweaking the algorithm. So the deltas that you get to play with and try to improve AV conduction and fusion, by doing that manually, they've achieved better outcomes on these patients. But again, this is not a fix-all algorithm. It's not the perfect solution. Again, heart rates change, intervals, conduction changes with heart rate, so fixed delta. So that interval you're going to take out of your AV delay to promote fusion isn't always ideal. So as your heart rate increases and conduction speeds up, you'd expect your delta to narrow, to be a bit shorter as well. And if you've programmed a fixed delta to start with, you will eventually lose fusion as a patient exercises or the heart rate speeds up for any other reason. Of course, if you have AV delays that are too long and you're aiming for fusion, you will lose this fusion as your LV will end up being activated by the RV pacing instead of being activated by left ventricular pacing. And if they're too short, you're not promoting fusion. And because one vector wasn't difficult enough for us to work with, there is also the option of turning on multi-point pacing, MPP. It requires very specific programming. So the actual MPP study by Niazzi et al. Showed that the programming with the best settings, with the best outcomes, would be the widest anatomical spacing. So just choose the vectors and choose the poles with the widest spacing between them, and program the shortest possible V to V delays, so 5 milliseconds in between. And that is what's advised for this algorithm. And this is, for me, a very simple guide of how to do CRT optimization by following evidence. Start out by measuring your intrinsic PR interval and QRS intervals, so you have a baseline to work with, and then test vectors. Now, after implant, once you see this patient in clinic, you're not going to be able to do a QLV, but measure the RV to LV conduction time, the LV activation times. And from here, choose which vectors. I normally go for 2 vectors to test, the ones that give you the longest activation times. From here, optimize the VV and AV delays and use fusion algorithms if appropriate. So if a patient doesn't have complete heart block, or if they don't have an extremely long first degree, it's worth trying fusion. And if required, try MPP and see what you can achieve. Now, there might be a bit of to and fro as once you change one of these algorithms or one of these intervals, you will cause a change on the ECG. So you will have to play with them all together. And once you're done with your optimization, measure the final QRS duration. And that's your documentation of how you've improved, hopefully, the QRS width. After this, in COVID times, I'd advise remote monitoring, along with a phone consultation to check in on the patient, a bit like what Fozia has talked through. And maybe it's time to start considering working with GP practices and community hospitals a bit closer, try and get an ECG done remotely, a current blood pressure, and get recordings of the patient's weight to assess their fluid status and whether they're overloaded. And then if you think it is required, then bring these patients back into clinic and re-optimize them. The one thing that is important that we keep in mind throughout this whole process is run 12 lead ECGs. You want to document everything you've done, not just for governance, but also to guide your process. every change you make, run a 12 lead. So key messages from here: CRT needs personalized optimization in order to be effective. 12 lead ECG is accessible, cheap, and it's a great guide for what we're doing. And patients may need to be re-optimized or not. Every patient's unique, and you might have done a great job from start. If you run into someone who says, I'll just turn on the algorithms, they'll know what to do, I'm not going to change any of the settings, or if they tell you, I'll just leave it on out-of-the-box settings, any CRT is better than no CRT, that's a big red flag. So I challenge them. And that's it. Thank you.
Thank you very much, Cristiana. Fascinating talk. I think, again, in the interest of time, we're going to move straight on. So our next talk is CRT and heart failure, diagnostics via remote monitoring, from Anna Domingos from Manchester and Becky Imms from Oxford. How's the tech going to work here?
Let's see. Good morning, everyone. I don't know if you can see my slides. Yeah, good. I was having some technical issues yesterday, so hopefully it will go well today. So thank you, Alistair, for presenting and doing this introduction. My name is Anna Domingos. I'm a cardiac physiologist at the Manchester NHS Foundation Trust, more specifically at the MRI, and I work very closely with device patients. So I'm going to speak a bit about CRT and heart failure diagnostics and what we do via remote monitoring. So, of course, heart failure is a very complicated syndrome, and heart failure hospitalization is something that we face more and more every day, and it's definitely a huge burden and a growing burden to the hospitals. We also know that in terms of survival of these patients, it decreases the more they have hospitalizations over time. So a lot of patients that actually have a first and second hospitalization, they will actually die probably within 1 year. So that's actually a huge impact in these heart failure patients. So of course, what we want to do is to avoid more and more these heart failure hospitalizations. They are definitely costly for the system, and with regards to our patients, it has a very suboptimal outcome. So we need to try to improve that. Just a quick overview of how heart failure is a growing burden for our healthcare systems. It has a huge percentage of representation in our healthcare budget in all Europe. Heart failure costs are actually quite high due to the readmission, so 60% is quite a huge burden as well as readmission rates. So readmission rates are quite high as well all across Europe. And as I've mentioned before, the median survival decreases year after year or every after hospitalization. So it has a huge impact in these patients. What we want to do with remote monitoring is have some tools that we can actually manage these patients and actually avoid as much as we can these hospitalizations. So remote monitoring with heart failure diagnostics could help to identify which patients are at the highest risk of heart failure decompensation. Of course, with the COVID, remote monitoring became even a more important tool in CRT and heart failure management patients. So here, just a quick overview. Fozia already spoke very well about how heart failure decompensation is achieved. This is just a typical progression of how heart failure can get to hospitalization. So each patient is different. This kind of progression can be different from patient to patient, but this is usually what could happen. So we have a decrease in the cardiac output that then will lead to more blood in the pulmonary circulation, less blood in the systemic circulation, and that will increase ventricular pressures as well as atrial pressures. That will also activate the sympathetic nervous activity, and then we can also have some observations on that through the heart rate or heart rate variability. Also, if this the system is not able, the body is not able to actually compensate, we'll have more pulmonary fluid, which more fluid in the chest will cause a decrease in thoracic chest impedance, increase in respiration rates. The patient has more difficulty in breathing. Last but not least, over time, of course, the weight will increase, and we get to a certain point where the symptoms start to be so bad that the patient is not even able to do their daily activities, and then, of course, the patient gets to hospitalization. So talking a bit more about what we have at the MRI. So before COVID, we had around 3,600 device patients, of which 69% were on remote follow-up. With COVID, things changed quite a bit. We currently have 5,000 device patients, of which 95% are on remote follow-up. So definitely COVID had a huge impact. We already had a lot of patients on remote follow-up, but definitely now we have much more. In terms of how we triage our device patients, and here I'm talking about ICD-CRT patients as well, with remote monitoring, we use mainly 3 manufacturers. So we have Boston Scientific, we use HeartLogic diagnostics to identify if the patient is at risk of any heart failure event. With Medtronic, we have, as well mentioned before with Foz, we have heart failure risk status that combines several factors as well. And last but not least, we have Abbott with their CoreView congestion monitoring. And these are the main ones that we use at the moment when we do our remote monitoring and triage of our heart failure patients. So when we receive downloads and alerts from all these manufacturers, of course, the action that we'll take, it will depend on, of course, all the diagnostics that we receive. So with this, I'm trying to say that we don't look at one thing isolated. It's all a combination of factors and diagnostics. Everything that we can get from the device is very helpful. Just to give an idea of what we do in our department, with Boston Scientific, ICD and CRTs, we take action when we receive an alert for HeartLogic and the HeartLogic index is equal or above 16. With Medtronic, ICD and CRT devices, we take action when the heart failure risk score is high. And with Abbott devices, we take an action when we have a score of 2 or more with the table that we present below. So when, for example, CoreView is triggering and you have one of the other factors as well triggering. So then we take action on that. And with action, basically what we do is to do a telephone triage. So this is a physiologist-led service that we do. We started this 1 year ago with one manufacturer, but it's across. So the idea is to do this across all manufacturers and provide this care to all our patients. So we basically do a questionnaire. This was done with advice of our heart failure consultants. So we do the main typical questions for heart failure development. And then, of course, you get like a score in the end. And of course, the score is basically just a score. So what we do is the physiologist that takes the questionnaire is the one that will decide if there is further action required or not. So the physiologist should use the clinical judgment to determine if an action is needed or not for that patient, because many things could trigger alerts. And of course, this is the importance and the role of a physiologist here. So what we usually do is if the physiologist thinks that the patient needs an intervention, usually refers the patient to our physiologist heart failure led clinic for further clinical assessment. So this will be a face-to-face appointment that we have. We can also refer the patient to our heart failure team. We're very grateful that we have our consultants and also the heart failure nurses team very close and can help us as well. So we can refer to them as well. And we can also refer to our weekly MDT. So these are the 3 points that we could use to actually take an action on our patient that could possibly be deteriorating. So just to show a bit of our experience with our pilot physiologist heart failure-led clinic, and just explain a bit the outcomes and how things have changed with COVID as well. This data that I'm going to present was collected over quite a long period, so more than a year. We started this pilot clinic just using the Boston Scientific Heart Failure Diagnostics, so HeartLogic. We had a total of 123 patients enrolled over that period of time, including CRTDs and ICD patients. From these 34 patients that we actually received alerts, we also had a total of almost 400 alerts, which appears to be like a huge thing. But just to explain why this huge number appears a bit scary, in the end, it didn't cause a huge burden to our service, to be honest, because with the HeartLogic, what happens is you will receive an alert every week, even if the HeartLogic index is below 16. So it needs to get to 6 to actually not alert anymore. So basically what we did, because we were doing a pilot clinic, was to record the data, but we didn't take action on 392 alerts, if that makes sense. So in the end, we did perform 15 interventions in a total of 12 patients. 11 of the interventions were performed in 9 CRTD patients for appropriate heart failure symptoms. And this included referral to our physiologist-led clinic, heart failure consultant, or heart failure nurses. The other 4 remaining interventions were performed in patients with ICDs. And basically, when we did the face-to-face assessment, we concluded that all the symptoms that the patient had were due to non-compliance with medications or other comorbidities like respiratory problems as well. So these patients were not taken for any further action with regards to heart failure. Also, and very important, I think this is the promising bit, is of the 9 CRTD patients that we intervened, 8 patients have had no further hospitalizations. One of the patients was referred from our clinic to the heart failure team, but unfortunately, a week later, he was admitted. The HeartLogic algorithm was useful in minimizing the heart failure admissions and identifying those patients that could be at risk. And definitely a physiologist-led service helped to shorten the time from the patient presentation to a heart failure review, because we all know it could take some time to have a heart failure consultant appointment. So it shortened a bit the streamline of the service. Just almost ending, but just wanted to show a case study of what we do. This is quite a recent case that we had. Also, it's not even a CRTD, it's an ICD dual chamber device that was implanted 2019. A patient with ischemic heart disease, paroxysmal atrial fibrillation, LV mildly impaired. We received an HeartLogic alert on the 7th of September with an index of 27, as you can see on the image on the right. Then we did the telephone triage, and the patient reported that had a new onset of shortness of breath and difficulty to complete her normal daily activities of living. So it was decided that the patient should come to our physiologist heart failure-led clinic. And on examination, of course, the complaint was the new onset of shortness of breath, denied any paroxysmal nocturnal dyspnea or orthopnea. JVP was not elevated. On examination, there was a systolic murmur as well, loudest at the apex. She presented with bibasal crepitations, confirming the amount of fluids that she had in her lungs. Also bilateral mild pitting edema up to her mid-chins. we did a 12-lead ECG that showed that she was currently in atrial fibrillation, and we contact our cardiology SPR straight away. The medications were reviewed. Carvedilol was changed to bisoprolol, and she was started on furosemide. Also, on the same day, an outpatient echo appointment was requested to assess her function because we haven't had an echo since 2019. We did also an MDT referral for the atrial fibrillation management, and the heart failure appointment clinic was requested. Also, last but not least, we did bloods on that day, and the NT-proBNP was very elevated. So that also confirmed our diagnosis. And this patient was then referred as well for EP to deal with and manage the atrial fibrillation. So we've tried the maximum to shorten the streamline of this patient, even though it wasn't a typical heart failure patient. It was an ICD dual chamber. So last but not least, just some final points. Of course, COVID-19 has had a huge impact in our lives and our daily practice. We had to make adjustments to our heart failure patients and how their monitoring had to be made. But I think combining the heart failure remote monitoring diagnostics with a physiologist-led service definitely helped to streamline the care that we have for our heart failure patients. Also, with our phone calls, of course, we can have feedback, and patient satisfaction with our close monitoring was really, really good. And I think it put their mind at ease during this really tough time, definitely. Thank you very much.
Thanks very much. Again, we've drifted slightly. We're supposed to, at this point, have a 5-minute break before resuming at 11 o'clock. Becky, have you got stuff to present as well?
Yes.
We better hear it then.
Okay, let me just check.
No time pressure, though.
No pressure. Right. Here we go. Okay. Okay, so I'm Becky. I'm one of the complex device nurses from the John Radcliffe. Slightly strange role for me working in cardiac physiology. It's a bit individual to Oxford, but in a nutshell, my background is nursing. I'm a cardiology nurse, and I work with the cardiac physiology team. My role is split, so I do sort of half nursing, but then I'm also trained in terms of managing complex devices. I'm in the lab implanting, and I follow them up as well, and have clinics following up device patients from both perspectives. So it's quite an interesting and varied role, but we're very integrated within physiology. So I just wanted to give a brief background. I won't sort of hang around too long on these slides because we've gone over them a little bit before, but generally in terms of our data locally, everybody went onto remote monitoring from COVID. It gave us a real push. And these numbers are vastly different, but you can see here our implant rates did go slightly down. They are definitely on the way back up again now. And I think we have sort of approaching over 3,000 patients now all on remote monitoring, and they go on to remote monitoring directly from implant at the lab. Every single ICD is followed up remotely every 6 months. Everybody gets a 12-week initial follow-up and a phone call. CRT we treat slightly differently. They are on remote monitoring, but we like to see them face-to-face, usually possibly between a year and 2 years, and then they're also on remote monitoring. So what is it that we're looking at when we're following up? So this goes for face-to-face and for remote. If we do need to see patients face-to-face, we're able to see them within sometimes that day, but certainly within 24 hours. But generally a lot of this is done remotely, and we can actually see more remotely from our diagnostics than you can in a face-to-face follow-up. But just running through this briefly, so we're looking at lead and battery parameters, we're assessing lead integrity, we're looking for noise counters, we're assessing a presenting rhythm, you know, what rhythm are they in, sinus rhythm, atrial fibrillation, and we're also assessing our EGMs there as well. Percentages of pacing, obviously key in biventricular pacing, we want that to be at least 99, 100%. If it's not, we start to question why. Arrhythmia, so again, have they had any episodes of non-sustained VT, any ventricular arrhythmias, any new onset of atrial arrhythmias that need some medication management there potentially? And again, those might be influencing on biventricular pacing percentages, and also we might need to consider looking at medication referral to EP and so on. But also, you know, as we've gone over, arrhythmia can be a flag for deteriorating heart failure, which I'll go into a little bit more. So we also assess histograms, that includes everything. So we can see such a lot from our devices. We're ideally placed really to be helping looking after these patients. Diagnostics, so activity levels, day and night heart rates, average heart rates, arrhythmia burdens, congestion monitoring, a bit of everything. And it's looking at everything as a whole and having a real multi-parametric approach to looking at your diagnostics. ECG, obviously very specific to more of a face-to-face follow-up, echoing what everybody said, always a 12 lead. I mean, we have a 12 lead on in the lab at every CRT implant. We optimise at implant, and then if patients are coming back into clinic for a face-to-face CRT follow-up, it's the first thing that we treat round and go and get is a 12 lead ECG. You can't tell much from one lead. So a basic check would maybe incorporate a V1, certainly, but I'm a big advocate for a 12 lead ECG if we're going to definitely be optimising in that check. Symptom management, which obviously is massively key in these patients. First thing that we do before we even get them all hooked up to the monitor is run through history. We find out all about how they are, their well-being, what else they've got going on. Social history is very important. We mentioned deactivation. That's also an important aspect of care for these patients and picking up things that might impact on things going forward. And it's important that we have an element of patient education about all of that as well, and symptom management. Medications. So one of the upsides of having a bit of an integrated team here in Oxford is that we have nurse prescribers. So we're able to look at medication, titrate, in clinic, write to the GP and request, and then we work incredibly closely with the heart failure team here under supervision of our consultant team as well. Other services involved, so any follow-up can involve a huge multidisciplinary approach. It's not just one person involved. A lot of the time these patients might be stable, hopefully, and they're not coming into clinic, but we do find them when they're sometimes not quite as well, and you need to act quite promptly and signpost them to the relative services. But even if they're stable, there's things like cardiac rehab, there's ongoing sort of heart failure education and follow-up, other areas of cardiology, certainly links with the GP and that type of thing as well. So there's a lot of people involved with managing these people. Programming changes and optimization and future follow-up. So, looking at consistency of follow-up, what's appropriate, do they need a closer follow-up? Can they be 6 monthly, or do we need to monitor things like arrhythmia and that sort of thing in them, and medication changes as well? So all considerations for everything we look at, which looks like a lot, but our general clinic appointments are between 45 minutes to an hour. And if I hold a telemed conversation with a patient, I allow half an hour at least. So I won't go too much into this because we have gone into it before, but obviously everybody knows, heart failure costs lots and lots of money. It's quite detrimental to patients. The more admissions they have, the less happy they are, and it's all linked to mortality as well. So let's try and keep them out of hospital. And again, pathophysiology. So we can tell a lot from our device clues in terms of if patients are potentially tipping the wrong way. And obviously heart failure symptoms are never static. They can sort of vary, and they kind of go a bit up and down at times, but we have a lot of diagnostic clues that we can look at. But again, it's a multi-parametric approach with looking at a diagnostic, and also it's your patient assessment that is particularly key. And so heart failure, increased sympathetic nervous system response is going to increase their heart rates. Heart rates at night is a particularly worrying thing if they're getting increased heart rates at night. And then obviously impedance monitoring, we can see all the ventricular arrhythmia burdens, and also quite clear is a decrease in activity level. Obviously, if patients aren't feeling very well, they stop doing everything that they would have done normally. So that's quite a key one for me. So I have got some examples here just to sort of go through, which are quite interesting. And you can see here, this is a CRT device. So whenever we look at diagnostics, we go over and look at the whole picture. And you can see here, there's quite a few key things here that would start alarming for me. And again, it's what's normal for that patient. So I know we very commonly obviously use NYHA class, but I think it's worth saying that it's quite a difficult tool sometimes, I find, because it is very individual as to how people are and what their perception of their symptoms are. And sometimes when you phone someone and ask them if they're well, they might say they're well, but then with a little bit more questioning, you might go from maybe an NYHA 1 right down to a 3 or 4 after some questioning. But you can see here quite clearly this patient's been quite well with lovely bi-V pacing percentages all the way along here, and then all of a sudden they dip right down to sort of 85%, and this would really, I'd start to be thinking here what's going on. Again, you can see that here the heart rates have gone up in correlation with the reduced bi-V pacing. Patient activity, so obviously they're starting to not really feel very well. So, and this all ties, this is a lovely example of a diagnostic, this all ties very well with someone that's really starting to not feel very well. They've then got an atrial arrhythmia burden going up, very close links with heart failure there. And then the thoracic impedance here. So it really does start to dip right down. And in this device, a decrease in thoracic impedance is an increase in fluid. Again, this is another diagnostic, but not a CRT one. But again, there's a couple of things here that would just create a flag for me. And it's about, you know, diagnostics can be influenced by other things, and it's not just taking one on its own, but it's sort of looking at the entire picture and then ringing the patient and actually doing an assessment over the phone, tying the whole thing in together and sort of having an idea about what might be going on. So again, here you can see the daily heart rate sort of start to day and night heart rates here start to creep up, and we all know that we like our heart failure patients to generally sit less than 70 beats a minute at rest. Again here, activity. So I think the two key ones, the three key ones here that are quite interesting are all these three diagnostics tie in quite nicely. So you start to get an increase in heart rates here, you're getting a decrease in activity levels down here, and then your thoracic impedance in here is going down. Again, that's just an example of a heart rate histogram that we probably don't want to see in our CRT patients. So again, you've got a lovely, beautiful spread right up from 50 all the way up to 130. You do want them to have a little bit of variability, obviously, especially the younger ones if they're quite active, but predominantly, and this is based on the SHIFT trial, isn't it, for heart failure patients, we like them more to be sitting sort of around here with a little bit of heart rate variability. So in Oxford we have a flag system which works quite well, so either from remote or face-to-face, and I think the more people use this, the more it sort of ingrains in, and we don't need to actually have it in front of you because it becomes like a natural thing when we're talking to people. So on this side, we've got the diagnostic almost flag as such, and then and some notes here. And we, so either nurses or cardiac physiologists conduct all these checks. And we are, as I say, predominantly remote. So first thing, obviously, bi-V pacing, increased ectopy count, non-sustained VT, and anything in orange is a flag to call the patient and assess symptoms and check in on how they are. I think, as I said, lots of these people might not be under community heart failure teams or under the heart failure service. If they are stable and have been stable for quite some time, they might have been discharged. So, you know, we might be, you know, in terms of cardiac physiology, the only service that might be following these patients up quite regularly. So I think this approach is very important to take. You know, we're reviewing them very regularly, and we can see little things that we can then refer on and address. Anything in red is an automatic flag. Obviously, that patient needs to be reviewed that day quite urgently. We do encourage patients to phone us if they have a shock or they're symptomatic with any arrhythmia. If they're unwell following a shock, obviously they need to come into A&E. But generally, if they have a shock, they're supposed to phone, but we all know that ATP sometimes can be completely asymptomatic, and shock therapy, sometimes people don't necessarily know, particularly if they have one at night, and it just will suddenly wake them up and they might not even be aware of it. So these come through as red alerts on our remote monitoring systems. They're reviewed every day, and patients get a phone call that day. And if we need to, we will bring them in for a review. And they're sort of fast tracked through, and we're able to assess their medications and make changes that day. Again, new burdens of AF, heart rate histogram reviews, day and night heart rate variations, activity levels and congestion monitoring. And then these are the questions that we would encourage everybody to ask. So a general question, you know, how are they? Any new changes, illnesses, changing condition and circumstances? Also, you know, we go back on EPR, check any hospital admissions, and assess sort of, you know, recent GP visits, you know, what's been going on. We also would have a look at their meds and see what they're on, anything that's been stopped, anything that's been started. How is your breathing? Again, and, you know, looking at a particular red flag, so new onsets of edema and PND and orthopnea, we would flag pretty quickly because that patient will probably need to come into hospital. You know, increases in weight and fluid potentially, and also there's an element of ongoing sort of patient education and a bit of shared decision making going on in here as well, with talking to patients about managing their own condition and recognising these symptoms themselves. And you know, are they still managing to do everything that they're used to? What's normal for them? I think quite a key question is how are they sleeping? If they've all of a sudden gone from sleeping with one pillow to being downstairs sleeping up in a chair, that would be a big warning sign for me to escalate management for that patient. Again, medications compliance, you know, do patients actually know what they're taking? So the more knowledgeable people are about their condition and their medications, the more likely they are to be compliant, so their outcomes are better. So it's a big, you know, the more we involve patients in their care and have that sort of shared decision-making approach with them, the more likely they are to engage and have better outcomes and be happier and not have these decompensating events, hopefully. And then again, like I say, lots of them might not be under the heart failure service, so it's worthwhile just double checking. If they are, that's brilliant, because that's a very easy phone call to the heart failure team. We have really close links with her, who will then manage that patient. So I think just some learning points for us. Device diagnostics do provide a lot of information that can detect risks of heart failure exacerbation. We can really help to reduce hospital admissions, but it requires a very individual patient approach. It requires a full assessment over the phone, including their medications, and sort of a whole picture of what might be going on, to formulate a plan to then take to your multidisciplinary team and manage that patient going forward. Multi-parametric assessment is absolutely key. It's not just one diagnostic, it's a few, and it's looking at, again, at that bigger picture. Communication and an MDT approach is absolutely vital. I think, you know, I'm not a heart failure nurse specialist. I review these patients and then I utilise my colleagues. Patient focus and support. So again, just a big shared decision-making approach with the patient leads to better outcomes. And that's me done.
Thanks very much, Becky. It's fascinating and great to see people crossing traditional boundaries as we try and integrate heart failure and device management for the benefit of our patients. I think we are going to have to move straight on, as we are now 10 minutes behind time. So we have another joint presentation. This is Comprehensive CRT Clinic Pre and Post COVID from Amy Brett and Laura Wickart, who are physiologists in Manchester. Over to you both.
Hi there.
Hi.
There we go. Hi, so we've been asked to do a hopefully quick presentation on our comprehensive CRT clinic here at Manchester. Just looking at how and why we set it up, how we've had to adapt it through COVID, and our plans for the clinic going forward. So it was back in, I think, 2017 that we originally started looking at our CRT patient population, looking at how they were followed up and if and when they were getting optimisation. And from these audits, we actually found that, you know, there was very little optimisation actually occurring. We found that a lot of our patients were getting implanted and just being left, as explained earlier, at the nominal settings, for example, LV1 to 2. And we'd follow them up as routine, and it was only if a patient kind of came to clinic and complained of worsening heart failure symptoms or anything like that, that we'd actually look at, you know, doing ECGs and fully optimizing the patient. And from the earlier talks, we learned that, you know, one size doesn't fit all for CRT. We want to make it as optimal as we can for each individual patient. So we wanted to set up a kind of gold standard comprehensive clinic for all our CRT patients. We modelled it on the Cleveland Clinic model, and they reviewed patients kind of in a comprehensive setting 6 months after their implant. So that's what we kind of went with. We brought all patients back 6 months later to a face-to-face clinic. The way we set it up, we did a session once a month. It was just a morning session. We had kind of 2 clinic rooms, and we saw up to about 12 patients at the time. We had, you know, 2 physiologists in each clinic room, and we were quite lucky to have usually a heart failure consultant in the clinic. If not, we'd have one of the registrars available. And the whole point of that clinic was to basically assess if the patient had responded to their CRT therapy. So we kind of set up a flow chart of how we wanted every CRT patient to be followed up. When setting up the comprehensive clinics, we kind of realised that we did need to make some changes at implant as well. So at implant, we wanted all device patients to be, you know, fully optimised. We wanted to use all the manufacturer-specific algorithms that, you know, were explained earlier to optimise the device. And we also wanted to record a lot more data. So we had basically the data available to compare 6 months later when they came back to clinic. We also found we needed more data regarding the echoes. A lot of patients, you know, did have echoes before the CRT implants, but we found that the echo could have been at a different hospital, or it could have just been a target echo to find the EF. Whereas we wanted basically more echo values to find the end diastolic dimensions, end diastolic volume, end systolic volume, and things like that again. So we had information to compare it to 6 months later at the comprehensive clinic. So when we kind of had fully optimized the device, we then brought them back a few weeks later to a clinic where we wanted to make sure, as long as everything was okay at that check, all our CRT patients went on to remote follow-up. If everything was okay, we'd see them 3 months later with a remote follow-up download. And at that time, we'd then refer them 3 months later, which would be 6 months post-implant, into the comprehensive clinic. And we'd make sure that they had an echo and their bloods requested. This usually happened about 2 weeks before the clinic, so that we had all the data available on the day at the comprehensive clinic. So in the comprehensive clinic, as I explained, we had physiologists and usually a heart failure cardiologist available. The physiologist would do 12 lead ECGs on all patients, looking at their presenting rhythm, how it was initially, how the patient came into clinic, looking at underlying rhythm, looking at LV only pacing, RV only pacing, and obviously any changes we made, again, reviewing the ECG to see how this affects the ECG. We'd again run through, you know, all the manufacturer specific algorithms to try and optimize the device. Obviously, Cristiana went through all that earlier, so I won't go through all that now, but we basically wanted to program the device specific for that individual patient. And at the same time, the heart failure cardiologist would be looking, you know, the patient's medications, at their symptoms, NYHA classification, and basically giving them a full rounded heart failure review. And from this, we were, you know, then able to kind of decide whether the patient had responded to CRT therapy 6 months down the line, whether they were unchanged or whether they were worsened. And from that, you know, if they'd improved, we'd then follow them up routinely remotely, but still bringing them back once a year. You know, as again, Cristiana mentioned, we, you know, the heart can remodel, so we'd still bring them back and do ECGs every 12 months. If they were deemed to have worsened or unchanged, then obviously dependent on the reasons for this, if it was a case that we just needed to up titrate medications or things like that in the clinic, we might just bring them back 3 months down the line and review, and then we can deem that they've hopefully now improved. If they continued to be unchanged or worsened, there was always the option to refer them back into a comprehensive clinic for further down the line. So yeah, this was all working really well, and then unfortunately COVID happened.
Yeah, so when the pandemic started, we cancelled all of our face-to-face clinics as per Trust national NHS guidelines, and we increased the use of home monitoring, as mentioned on the previous talks. We did still want to kind of have some kind of comprehensive CRT follow-up, because we kind of prided ourselves on the clinic that we already had, and we wanted to maintain some kind of comprehensive follow-up for these patients. However, we knew we couldn't bring these patients into clinic as these kind of routinely, as these are the patients that we asked to isolate. They had a lot of comorbidities, and they were the ones that were the high risk really for not doing too well if they caught COVID. So we needed a new way of working, and we were kind of considering whether to do a telephone clinic or like a video kind of clinic. But as people have probably seen already, the video clinic was not really the best idea. It's taken us 4 computers to be able to find a video technology this morning, and we thought patients might struggle with that. So we basically developed this telephone clinic, and we started this probably around May, June 2020, so a couple of months after the pandemic, when we realised it was going to be like an ongoing thing. So with this telephone clinic, the idea was basically to filter, triage the patients to see who's responding or who's improving and who's worsening. So the worsening patients, or the patients that aren't, responding to the CRT, we can kind of refer them on, or treat them and identify them really. So this was our new workflow for about 12 months or so. So patients, everybody that had a CRT implant, we gave remote monitoring at the implants, and then our 2-week wound check then happened to be a telephone call and remote follow-up. And on the phone call, we'd ask if the wound's healing okay. If there was any issues, we would bring them back into clinic, or we'd ask them to send us a photo over email or something if that was possible. And then we had this telephone clinic 6 months down the line. So for the improved patients, and I'll go through in a second what we deemed as improved, we would refer the patient then for a routine echo, routine bloods, a 12-lead ECG but no optimisation, and then kind of continued remote follow-up. For the no change or worsened, we wanted to kind of maybe review them a little bit closer. So for the worsened patients, it depends on kind of what they reported. If they reported heart failure symptoms, or we were worried about what they've reported, we would kind of bring them into clinic, hopefully within a week, and we'd be able to perform echo, bloods, ECG optimization, and then kind of plus or minus getting one of the heart failure team or the heart failure consultant involved, just so we could keep a closer eye on the patient and work out if it was a heart failure decompensation that was occurring. So this was kind of the performer that we used during the telephone clinic. So we reviewed the last download, which was ideally a day or 2 before. So we had things like if there was any events on there, if there was any heart failure diagnostics that had come through as wireless alerts, what the presenting EGM was. So that gives you an idea really if there's definitely LV capture, or if there's a problem with the lead. And then also obviously percentage by IV pacing, which is really important. And I guess the new part of the clinic for us was asking the questions over the phone. And I guess I didn't mention, this was purely a physiologist-led telephone clinic. So it was important that we could identify anybody from specific questions. So we wanted to know if they'd had any heart failure symptoms at the time. So we took some of these questions from other clinics that we had. As Anna mentioned earlier, the heart logic questions, some of these were based on that as well. So has the patient had any recent illnesses or hospital admissions for heart failure or COVID that could be adding to their symptoms? Do they have any swollen ankles? Are they suffering from orthopnea? But then ultimately we wanted to know if they were responding from the CRT. So we wanted to know if their exercise tolerance had increased as well or changed. Now, this was quite subjective. As you can imagine, a lot of the patients were staying at home. So a lot of the reports were that they didn't know if their exercise tolerance had gone up because they haven't been out, they haven't been walking. So it was quite difficult really to assess response, I guess, looking back. And we'd obviously ask them how they felt in themselves. So the patient global assessment, whether they felt no change or if they had improved. And like I say, we had quite a close relationship with the heart failure team. So as physiologists, even though some of us have got clinical assessment skills, if we had any worries, we would refer the information we found onto the device MDT or straight through to the heart failure team. Okay, so the feedback to this telephone clinic was very positive. Patients, well, quite a lot of the patients hadn't really seen or heard from anybody from the device team or the CRT clinic since their 2-week post-implant check. So they kind of, really appreciated being able to speak to somebody over the phone, and then when necessary, a face-to-face appointment as well. One more thing to mention, I guess, is I mentioned the patients that had improved had a routine echo and a routine blood referred, but this didn't always happen. We kind of thought that referral would happen in like 2-3 months, but actually as the pandemic went on and on and on, it actually took maybe 6 to 12 months before they actually got that echo.
So yeah, as Amy was just saying there, we realised that patients weren't getting the service that they were getting prior to COVID, obviously for reasons out of our control in some cases, but as and when we could, we wanted to get clinics back up and running for these sort of patients. So it's about spring this year that we kind of thought, right, from August we're going to try and set up our clinics, certainly for our CRT patients to come in again and get the full review that they were getting previously. So it runs in a very similar way to how we previously run it. We have changed it slightly due to clinic room availability and all things like that, and also consultant availability. So we now do it as a full day clinic rather than a morning clinic. We still see about up to 12 patients, and we just run it once a month. But this time we've decided to make it kind of a one-stop clinic. So as I mentioned, patients used to come a couple of weeks before for blood tests, echoes, things like that. COVID still hasn't gone away. We don't want to be bringing patients in unnecessarily. And I think it's just kind of a good standard to set, that the patient comes in and they just get everything done on one day. So yeah, we bring them in, they can have their echo done. We're lucky that we have an echocardiographer that can carry out a full scan and report it at the time, so we can get the echo measurements. We can get bloods done on the day, and again, they're usually back within 24 hours. And we have started improving the way that we kind of triage the patients that come to this clinic. Originally, it was anybody with a CRT came to the clinic, but we did find that some of the patients turn up and they were barely bivent pacing, awaiting a His ablation, or they could have been a block HF indication, or ultimately could have had a good EF and it was implanted for other reasons. So we now triage that it's just heart failure patients that we see in this clinic and that can benefit from our full optimization. So again, the flow chart, implant, everything's very similar. We still get all the measurements that we got before. The other thing that's changed due to COVID, we still keep our 2-week remote follow-up appointment and phone call. So everybody at implant gets a remote monitor. Again, we follow them up 3 months later, and then 3 months after that. So 6 months following their implant, they come into the comprehensive clinic where they get the full review, echo, bloods, everything done on the same day. And again, we just deem whether they've improved or worsened.
Okay, so yeah, so this is kind of our new performer, which kind of incorporates everything that we do in the clinic. So there's a few bits that we'll just highlight here. So we've got the kind of, when they come into clinic, we've got all the device download information. So how their LVs set up and what vector they are, what their underlying rhythm is. We can compare the QRS durations as well to make sure that the final by-event pacing QRS duration is much shorter than the underlying rhythm, hopefully. Percentage by IV pacing if there's any episodes. And then we have kind of the echo data. So we fill this in at the clinic or after the echo's been performed. And it's, I'd say, the past couple of months as we've brought this clinic back, we've been kind of more defining the response from the echo. So we do use echo as kind of, I guess, the main feature for whether a patient's responded or not. Opposed to over the telephone clinic, it was very subjective on patient symptoms. So kind of for a responder, we use if the patient's got a 5% or greater ejection fraction, we deem that as a responder, as well as the greater than 15% improvement in the LV volumes as well. And then so we document that. We've got the questions as well, which we've kept on there, but during this clinic there is a heart failure consultant that kind of tends to take over that part of it. And then because the patients get the bloods on the same day as well, we just have to make sure that either later on the day or the next day we've got somebody to review the bloods. And we have this performer that gets uploaded to our electronic like EPR system, basically, which kind of goes through so everybody can view it and everybody can see if the patient is deemed as a responder or not. It is quite an admin heavy clinic to set up, but with having this kind of performer and collecting all this data, it's really good for audits and having a look at actually how many patients do respond to CRT. And we were hoping to have a look and see whether the 70% of standard responders is higher in our centre. So that's kind of where we're going next with this. And thank you for listening.
Thank you both. Another fascinating talk. I think in the interests of time, we're going to have to move on. And at this point, I'm going to hand over to Dr. James Gamble, a heart failure consultant in Oxford, who's going to chair a panel discussion on the issues that have been raised by a series of fascinating talks. So over to you, James.
Thank you, Dr. Slade. So I've got with me Colin Cullington, who's a heart failure consultant in Manchester, Alice Reid, who's one of our senior cardiac and devices physiologists here in Oxford. I've got Neil Herbert, who's a highly specialised cardiac physiologist in Manchester, and he's at the Manchester Royal Infirmary. And then I've got Larry Roberts from also the Manchester Trust, but from Wythenshawe. So we've got 3 different hospitals and 2 trusts, so a bit of a sort of a range of opinions. And I thought we thought we could just try and discuss some of the issues that we've raised, which I think are really interesting, aren't they? It's really interesting to hear how different people have got on with these things and what's worked. And I must say, I'm quite jealous of a lot of things you've managed to set up in Manchester. We've been talking about a CRT clinic along those sort of lines for about the last 4 years and never got anywhere with it. So well done. So I suppose, in terms of the changes you've made since COVID, what do you think has stuck and what do you think should stay? Maybe if we start with Colin.
Yeah, thanks, James. So I was thinking about this in the preparation of this webinar. So we essentially made some initial changes which were forced, and as everyone was, in terms of essentially stopping all face-to-face activity except for dire emergencies right at the start of the pandemic, and then it's gradually sort of headed back more towards normal. So in our centre, we already had a large number of device patients on remote follow-up. So I think Anna showed the data there, it was about 69%, and then we moved that up to sort of 95%. So for us, it was relatively easy because we already, had a large number on remote follow-up to begin with. But for other centres, and perhaps we'll hear from some of the other panelists, it's been more challenging to move a larger percentage of their patients onto remote follow-up. But those patients have stayed on remote follow-up, and like others said, we're giving out remote monitors right at the time of implant. We have done away with that first face-to-face check, which we used to do at 2 weeks. We now do that remotely and with sort of telephone discussion about wound healing, etc. That has stuck. In terms of our more sort of complex services, then so Amy and Laura's now talked about our CRT clinic, which we're very proud of. So that sort of moved to a hybrid model, but now that's not one of the things that's stuck. That's now moving back to how we did it before COVID, so fully face-to-face. But I think what this sort of whole discussion talks about is the important interface between all the different team members involved in these complex patients' care, and how we're using technology to try and prevent hospitalizations and see patients out with the usual heart failure clinic settings.
Yes, I mean, Alice can talk to how we found it in Oxford. I think we came from a much lower baseline of remote monitoring, particularly for non-complex devices, and so it was racking that up that was a challenge.
Absolutely. So as you said, James, we came from a purely face-to-face follow-up for both Brady devices and CRT devices. And at one stage during the pandemic, we were trying to enroll every single Brady device onto remote follow-up only, which we very quickly found wasn't sustainable, just from a sheer sort of workload and managing that with our staffing. Yes, so for our heart failure specific patients, we've now moved to a hybrid model with a 6-monthly remote follow-up rather than face-to-face, and 2 yearly face-to-face follow-ups, which I think is something that we will probably continue with.
I think that comes back, a lot of the issues around all of this, isn't it? It is how you make these things sustainable in an NHS model, because it's quite hard to make the finances work for most of cardiac physiology generally. It's not very well funded, is it? But we make the money from the implants, and then the follow-up, the trusts don't like and don't fund. How have you managed to make the CRT clinic work from that point of view?
In terms of our sort of moving to a hybrid model?
Yeah.
So I think a big thing that has certainly helped is trying to utilize more sort of app-based technology, because obviously that's something that is sort of, we don't have to provide these remote monitors, which means that we can allocate them to a lot more people. The difficulty with that is finding patients that are suitable for those. CRT generally, CRT patients are more of an older generation and perhaps aren't suitable for that. But in terms of, we're lucky in that actually we certainly have a good support network, and I think the fact that we can sort of increase the capacity and see that many more patients has certainly helped in terms of funding, because that's what generates the sort of revenue for the follow-up clinics.
And I know that's part of what we've been doing is converting what used to be outpatient, in-person slots into remote, so that they're getting converted across, and we're beginning to move the workforce from the clinic to the remote, which is where the workload is.
Absolutely, and we're currently going through a clinic restructure that both increases capacity for both face-to-face and remote follow-ups, and that's certainly helped to, streamline that whole process and ensure that we are able to see more patients and quicker.
I think that's, sorry interrupting, but I think that's reflected across the country. The BHRS issued a remote monitoring survey in spring, and from the data, you're right, most people had ICD, CRT-D patients on remote follow-up, and there seemed to be a 60% increase in patients with pacemaker devices having remote follow-up introduced as part of their follow-up package, and then a further 30% of CRT patients. So I think, like you say, that's reflected nationwide, that there's been a massive change in practice. And that was achievable during the pandemic because there was finance and availability and the drive that we had to react in following these patients up safely without compromising them having to come to a having to come to a face-to-face follow-up. And like you said, it's sustaining that financially now, isn't it? And I was at a meeting the other week where people have suggested that there are occasionally NHS innovation finance pots. So sometimes if you are struggling to secure devices for remote follow-up, it might be worth engaging with your finance department and asking them just to keep an eye out on innovation pots and potentially gaining additional resources from that aspect. But like you say, app-based remote monitoring is definitely one of the alternatives that's going to be heavily utilised. And I think we're finding that actually more and more patients have suitable phones, don't they? And if not, they've got an iPad. Somebody in the family has an iPad or a tablet that they're able to connect with. So it's like you say, engaging with these patients, engaging with their support network at home, whether it's family members or spouses or relatives. Then yeah, full engagement.
So I think here at the Manchester Heart Centre, we probably had a different experience than a lot of centres around the country, wherein the transition we found relatively smooth. I say relatively smooth. If I never have to pack another CareLink box again, then it'll be too soon. But we've alluded for some of the reasons why that might be, in terms of we had a large number of patients on remote follow-up already, so we were very used to following up quite a large percentage of patients or a large volume of patients. But there certainly are, I think, other reasons for that as well. So we used the OnePulse platform, which rather than having to trawl through individual vendor sites, that pulled it all through onto one platform. Although it's not a perfect system, it did make it easier. We actually did an audit and we found that we are more efficient actually following people up remotely, and that's even more so when we're actually working from home, when you've not got the distractions in work. We also have great admin support as well, so CAT takes away a lot of the, if you want for a better word, trivial side of things in terms of changing appointments as well, so you can probably just focus on the download. So we had that infrastructure in place already, so we kind of found the workload transition okay. However, it was a complete change of working pattern. Physiologists are generally kind of social creatures, I would say. So we like working with patients, we like working with our colleagues and banter, and that was just taken away overnight. And especially even more so when you're working from home and when you've got 10 hours just talking to the dog or yourself. And despite the picture behind me, it's not always kind of sunny in Swinton. So that side of it, I think, was a real hard part of the transition. But I think coming out on the other end, we now have, because we can follow up all the easier patients, if you will, the Brady and the ICD patients remotely, and that's kind of packaged away. We're used to doing that, that's done. We now have the resources, the time to focus on the patients who actually really need it. And obviously my other colleagues have mentioned how we're doing that in ways at Manchester. So I think that model, certainly for us, certainly works at the minute. And I think we'll probably see a lot of centres heading towards that way.
Yeah, that's right, Neil. So we have a lot of sort of space now for sort of diverting our resources to more complex patients, particularly heart failure patients. You talk about the finances, James. We know that heart failure is extremely costly to the NHS. Any admission that you can avoid is saving money. So you're offsetting the cost of sort of moving your simpler devices to remote follow-up by putting more resources into preventing these expensive hospitalizations. And I think we're in a learning period about all of these sort of device-based alerts. You know, that the data is coming out now. I think they will be useful. And we know that the alerts are sensitive for worsening heart failure. The issue is that they're not particularly specific. So you have to then follow up the alerts with an interaction, usually a telephone call. But we've heard today from both physiologists and nurses how these sort of traditionally medical roles are now sort of being shared out amongst different healthcare professionals. Physiologists are upskilling in clinical examination, and you know, we're all becoming part of a sort of more interlinked team, basically, to treat these potentially very sick patients and try and keep them out of hospital.
Yes, I think that's so important, isn't it? That if you can have all the alerts you want, but if there isn't a way of improving something hard and relatively quickly from that alert, then you don't get anywhere. And that's the key, isn't it? Because if you look at all the remote monitoring trials in the past, the big failing has tended to be that it takes too long to change something. And we know that if you wait ages after you get the alert, it's too late. They're already in hospital. So I'm sure a lot of it, as you say, is having an efficient team working approach where you can change something pretty quickly to intervene. So I think in terms of the interests of time, although we could talk about it a bit longer, we probably should stop. And I think we're handing over to Stuart Allen for the closing remarks.
Yep.
There's probably a little bit of time for questions at the end. I know some people will have to go, but if anyone wants to stay on and ask questions, then at least some of the panel can probably hang around for a bit.
I'm just going to go through the chat box very quickly to see if there's any specific questions. But I mean, a lot have said how good they've enjoyed it. Yeah. So I mean, I guess what I think I want to say thank you again to the presenters that put together a very interesting webinar for us today. And obviously, particularly thanks again to Anna and Cristiana, who are tasked to putting this together and have done extremely well. And like my colleague alluded to, we could talk about these things all day. But obviously trying to keep us focused and have everyone have time to do these kind of webinars, we try to keep them to 2 hours. But yeah, in terms of today, my personal views, I think the take-home message is you need an holistic view to CRT and heart failure follow-up. But you cannot work in isolation anymore with devices and heart failure, and we need to put in extra resources to ensure that 20 grand's worth of kit that you've put in is actually going to do some good for the patient. And it does require new ways of working. And as my colleague Neil said, is that although some of our work has increased in computer-based work, which is not what physiologists signed up for, we try to balance that with 90% of the patients that we see now in the week are CRT patients, which generally require much more programming, much more and a different skill set. And so I certainly think that model or similar model to what we have in terms of ensuring that the nurses, the doctors and the physiologists, and that's just not the CRM physiologist, that's the echo physiologist, are all working together to produce the data points that we can make a decision on whether that patient is responded or not. Yeah, I think that's all I've got really to sort of sum up. Just let you know, there will be BHRS is committed to providing education resources for its membership, and this webinar is part of that. And we have several other webinars planned going forward to try and bring you at least similar, as interesting as we had today, in different topics around CRM management, including heart failure. So again, thank you once again to all the panel, and obviously thank you to the chair of BHRS, president of BHRS, I should say, sorry, Alistair Slade, for chairing the meeting today. And with that, I'll thank everybody and wish you all a good rest of the day. Thank you.